my
Without
gavel.
fail, sometimes too, but that's a good day.
I want to welcome everyone to the Mason County Board of Health regular meeting, September 26, 2017 at 3 p.m. Introductions. Randy, we'll start with you.
Randy.
Dave Wyndham.
Kevin Chudy.
Terry Drexler.
Kathy McDowell.
Peggy Van Busker.
Dave Gardner.
Todd Parker.
And Debbie Riley.
Very good. Thank you very much. Did you all look over the agenda?
I would make a motion, we approve the agenda as
Okay.
submitted.
Second.
All in favor?
Aye.
Aye. Opposed? All carried. Approval of the minutes of July 25th. Did you all take a look at that?
I don't think you guys stuck in the packet.
Oh, it was in mine.
Yeah.
They're in our
Yeah.
book.
All right.
Yeah.
I make a motion,
Would you
we
like to look
approve,
at them?
I make a motion, we approve the agenda, or not the agenda, the minutes as presented for July 25.
A second?
I'll second.
All in favor?
Aye.
Aye. Opposed? Motion carried. We will have, well, we would have had Dr. Yu give a report, but Kevin's going to give a quick report. She is not here today.
For the record, I'm not a doctor. Just play one on TV. Just very briefly, and Commissioner Nowood can fill in some of the gaps as well, but Dr. Yu has been working with a group of stakeholders up in North Mason to host a forum regarding the opioid epidemic and to kind of gather resources to have a response. Abe was also at that meeting, and appreciate everybody coming up and coming together on this issue. Is one of the main areas that we talked about throughout that meeting was this transcends socioeconomic and demographic, and really is a problem facing the entire county and beyond. So I think they have set a date for November 15th, I believe. In the evening, it'll be up at North Mason High School. So really encourage everybody to get out and attend. If you didn't attend the one in Shelton, it'll be very similar to that. And I hope we have an equally large turnout and really try to capture the enthusiasm that a lot of folks are bringing to tackle the problem.
I think,
You may speak.
not to interject too much, but what I appreciated about looking at the agenda outline, I was not at that meeting, but the agenda outline versus the forum that was done in Shelton, is that this is also a good education piece about, number one of the issues is the difference between recovery or addiction and dependence, that's it. And then also outlining, these are the services we currently have available, which didn't really get captured in the first one. And so on that effort, I noted a number of service providers that were not presented, and so, or weren't represented at that initial meeting. So I forwarded those on to Bo Bakken with the North Mason Fire Authority. And I'm hoping, it could be a long drawn-out session between all of those topic areas, but I'm hoping there will be an opportunity for all the service providers to also share what they're doing, because I think we're doing some pretty creative things here.
Okay, anything else on that? Next, we'll have Dave Wyndham with his administration report.
So if I take just a minute to walk you through your package, you got this with the first part. I had my piece from the director's desk. Unless you have questions, we'll just kind of shoot past that. It was pretty self-explanatory. One of the documents I really like to get into is the finances. So that's going to be a part of your packet each quarter. We're going to look at finances just to keep everybody up to date on how we look. The first chart at the top is revenue versus expense. Think of that as profit and loss. So one of the things that you look at with public health funding, because it's so much of it is grant driven and there's county contributions, it's not going to look the same as, say, the building planning permitting side does, which is more of a reflection of cash in, cash out. So, but what allows us to do is to track trends over time to make sure we're not getting out of whack anymore. So That's the top one. The next one, public health operating expense, it's a little confusing, I realize. The first part says vouchers is actually 2016, and then the next little group of bars that are held up is the 2017 report. So the reason 2016 looks very high in operating expense in June was because all our indirects were taken out in a single month, where this year we're taking them out every month. So it's not that huge hit all at once.
I have a question real quick.
Sure.
What, on the expenses versus budget,
Mhm.
there's such a spike in that.
Okay, I'll come
You
back.
come back, at least explain it
Right.
in the
So,
report.
fund balance, you can see we started off the year, we got influx of cash in June, or excuse me, in January. Downhill, we got another influx of cash in July, which is our second half of our community health block grant,
Okay,
public health block grant, excuse me. Now, the bottom one, the big spike in gray is, again, that's the indirects that were taken out all in 1 month rather than spread across the year.
oh, okay. Is that the way it always is?
No, this year we took it out every month. So you see, we bent the curve downward in 2017 on that more of a
Okay.
navy blue line.
Okay, I see, okay.
And then the bottom graph on that shows the orange line is our salaries budget, which is nearly identical between the 2 years. It's like $1,000 different. And we're staying right where we need to be.
You came down a little bit in October,
Mm-hmm.
and is that normal?
But yeah, last year we came down in October, we had a change out of people in October last year.
Okay,
So, and now, this year, we had people change out, but part of that expense. So we had some older employees who retired, brought new employees in. The reason you're not seeing a bump downward is because I brought the new employees in and they overlapped for a month to get training. So as people left, our expenses, it all evened out.
okay, right,
Right.
okay.
So, and what it allowed us to do was to take and amortize that savings and put it into training at the front end. So it all works out.
Okay. Thank you for clarifying that.
So the next piece after that is a piece that DOH and WSAPO have put together. And this is for boards of health or administrators or whoever. They can. So what does public health do? And what are the regulations that back it up? This is it.
Yeah,
This is
And
huge.
it's huge. It's a lot more than people think.
yeah.
Uh,
I've
So-
always been amazed.
Yeah, and so it breaks it down by RCW, WAC, and then of course, if you were to look at us, we go to chapter 6 and chapter 8 of the Mason County Code, and we have our own piece we add to that as well. So,
Very much appreciate that. I'm gonna take this out of the book and put it on the wall.
right, so this is a to-use document. So if you have people who call you and say, well, what about schools, or what about, what,
Mhm.
you could pull it out and refer right to the
Yeah.
RCW, so without having to do a lot of searching.
Wish I had that for everything.
And
Yeah.
This is handy. This is really handy. So kudos to WSAPO and to DOH for putting this together.
Yeah, very good.
So it's just a very good reference. And we need to make sure this is included with each new board member's packet as they come on board. So they have this as their go-to reference. It probably should be at the very front of their board book and just stay there.
So they can say, I think, I'm overwhelmed.
Yeah.
Anyway, you're overwhelmed anyway, but,
Yeah.
you know.
But, I mean, this does lay it out, and I referred to it today. I was working on some things in Group B water systems. And it's just a flash, pull this, and then go to the computer, and not have to do any searching through. Because seriously, the state's legislative website.
The worst, anytime you mention the word septic, it's in there.
Yeah.
And I have to use it. That's why I love this, because I'm one of those people, I do that, and I read forever before I finally get where I need it.
Right. So this really makes it a lot easier to get to those things that you're gonna need to access. And then it also answers those really off-the-wall ones that come in every once in a while. So, housing or homelessness or whatever.
So you just go to the website.
So, yeah, it's got the RCW,
Mm-hmm.
and then on the outside, it's got the Washington Administrative Code that will
Right.
apply. So it makes it very easy to find these by reference.
Just go to the website and then they'll
Yeah.
click in that number
Actually,
where
I
you
just go
need
to
it.
Google and I put in RCW and the number, bang, it comes straight
Yeah,
up.
it comes right up.
Really?
Yeah.
That is really cool.
Yeah.
I'll have
So
to
we're
try
actually
that
working on
tonight.
an app that would do the same thing. So, hope to see that in this,
So, I guess the next step, I know you've been speaking a lot about foundational public health services. I guess the next step would be nice to have you kind of outline, using this list, is what's been identified as foundational.
Okay, so, okay, I can do that, because a lot of this stuff is what would be considered foundational because it is mentioned in law. If it's in law, we have to do it, we consider it foundational.
So the whole thing.
The whole thing. This is, yeah.
Foundational is law.
So if you were to take foundational and break it down into a way that you could explain to somebody in an elevator, if it's required by law, that's foundational. If it's something that we do and people don't get paid for, like epidemiology or assessment, that's foundational to public health. And if it's population-based, so now population-based could be, let's use vaccines. It's not giving somebody a shot, it's making sure that shots are available across the population. If the person who gets the benefit can't be identified specifically, that's population-based health. So you don't know who didn't get sick because the water was good. That's population health.
Okay.
So as opposed to how a lot of the hospitals look at population health is the people who come to their hospitals is their population. But public health goes much broader than that and looks at the entire population.
Okay.
So think of it as if you can accidentally bump into bad food, water, air that affects your health, a disease, that's foundational. The more something you do yourself, the less foundational it becomes.
All right. All right.
There's a lot of stuff that we're required to do. And there's a lot of things that the state is required to do. There's overlaps as well. One thing that you dig into it, if we don't do it, the state can come in and charge us to do it. So that's under the financing piece of public health. So, and then I've seen them do it. They're pretty expensive when you do it.
Unfunded mandate. You do it, but you better find the money to do it.
Right.
Right.
Some of these programs do have money that come with them, shellfish and some of these things. Some of these, they make the assumption that we're going to do fee for service on-site and water, those sorts of things. A lot of it is just buckets of money, and a lot of it is the county contribution. So, for example, tuberculosis, that is in the state constitution. It's there, and it's the responsibility of the counties. So a lot of the regulation in the state constitution, I think, goes back to the flu outbreak of 1918. And they put a lot of the powers under the health officer into the state constitution back in that time period.
Okay.
So I'm going to skip the profile on homelessness, and we'll come back to that. I did want to talk about, on the last page, is this proposed tobacco vaping prevention work plan. As, not in specific, but as an example of how Cascade Pacific Action Alliance will be working with local public health. So, in my work on the board of both the Campbell Community Health, which is Cascade.
Pacific Alliance.
Yeah.
What is it?
Cascade Pacific Alliance.
Cascade Pacific Action Alliance.
Action Alliance.
CPAA.
Okay.
And they're a subset underneath Choice Health. And Choice has been around a long time. So CPAA is the accountable community health that was required under Healthcare Authority about 3, maybe 4 years ago. They came out with this concept of accountable communities of health. So in the interim, Accountable Communities of Health have started to stand up. They actually got certified over the summer in their phase 2 certification. So they're actually now they have all their financial pieces set. They are an actual corporation now, have the ability to receive and distribute monies. So they've gone through all that accreditation piece. In my discussion with folks on the board and with this Medicaid demonstration project, I'm not going to see, I don't think, a lot of money come down to local public health. So if you're to take this is an example, this is marijuana and tobacco prevention for youth. The money went out to one of our partners, which in this case would be Thurston. Well, actually, it is, SK Pacific is actually running this themselves. But money will be going out to partners, not necessarily public health. So our piece of this pie is to participate in going to meetings and going to planning, a very small chunk of money, that's $4,000. And the idea is that Cascade Pacific, once they have a plan that will help being developed by local public health, will come into our communities and do the work. And we'll wait to see how that works out. I've had that in the past with Spokane, and it's not worked well. It hasn't really actually left, it didn't actually leave the boundaries of Spokane County. So the money was used before it got out to the smaller communities. And in some ways, I can see what they're trying to do in that this money was $4.2 billion that was taken from Medicaid clinical intervention work. So just think paying for Medicaid services. It was set aside to do work that affects the social determinants of health, housing, jobs, those sorts of activities. Well, in that massaging since then, and under the influence of the Healthcare Authority and other agencies, it's kind of gotten back into a clinical intervention mode again, and which really leaves out public health. So a lot of that money is going to be going to hospitals, it's going to be going to clinics, mental health, those sorts of things, not really addressing the social determinants of health. So the piece that we were brought in to work on and brought in to address is kind of being set aside, and they've gone right back to clinical law. So they have to bend the cost curve 2% in 5 years, and they have to pay money back to the state. So if you are just serious about bending the cost curve,
It doesn't make a lot of sense to spend a lot of time in rural communities, because even if you're 100% successful, you don't have the population.
necessary to move the needle far enough. So I think you'll see a lot of the effort being spent in the major communities with the Medicaid community, and because that's where you get most of the movement to bend that cost curve. So one of the things we're trying to do, being at the table, saying, hey, although that may be a financial decision, there's an ethical decision to make as well. You can't just write off the rural communities.
Right.
These services still need to come out to people out here who don't have access to urban services. So we're talking amongst ourselves in public health, and that's our goal, is to make sure that those services aren't concentrated in urban areas, and they do come out to us. Our populations are just as important as those urban populations. So this is just an example I wanted to bring up as this process goes along. We'll talk about some other things that we can get involved in. And the opioid crisis, Dr. Yu and I have had a number of long conversations on this. So at the local level, Dr. Yu is going to be very, very involved and just absolutely the champion on that. And at the regional level, that's where I'll step in and work on the regional pieces to make sure that we're not left out of that puzzle. And by splitting up our efforts that way, we can probably be more effective.
And what does at the local level mean?
Well, Lydia's got an announcement on that.
Earl, can I wait?
You can wait.
Okay.
So we're
Because it
gonna,
fits into everything else I'm talking about.
Okay.
so we've been working hard on some of those things, and Lydia will get to that.
Okay.
Dr. Yu is working with North Mason. We've been talking with paramedicine about doing some opioid intervention work. Really, it's on the ground work, where at the regional level, we're trying to get the pieces in place and try to figure out how the BHOs interact with that, how the Medicaid organizations work with that, the MCOs, because there's going to be a transition in 2020. What does that transition look like? Nobody knows, because we handle it differently in each region. So our region is one of few that has more than one BHO attached to the region. So, but I think the two BHOs are pretty much in alignment
Mhm.
on how they're moving forward. So we're not going to be early adopters or even early mid adopters or late adopters in order for the behavioral health organizations to get themselves set up in a place where they can continue to develop services locally without depending on managed care organizations.
And the behavioral health organization staff have been having a lot of conversations with the managed care companies, the insurance companies, who despite what the healthcare authority wants, they want a hands-off approach to the management of the behavioral health care. They're not staffed up to that. That's not their specialty. They're more clinical care type of folks. And so we think that we'll be able to move hand in hand with the insurance companies to just design the system that best suits at least these two counties,
Right.
and including the Grace Harbor area.
Because the managed care organizations don't want to own buildings, they don't want to own facilities, they don't want to build facilities. That really is something that should be driven by the local communities that say, oh, we need an ENT facility, and then the managed care organizations are a payment model that's attached and kind of runs across, as an umbrella across all of the work. So, but it doesn't, I mean, they're managed care organizations for the Medicaid population, so they're really not touching everybody. So that's where it gets stickier.
Okay. Any questions about any of this?
One piece I did kind of push back on,
Oh.
and Commissioner Jeffries was there
Yes.
the last one, was that we're spending so much time and effort on this Medicaid funding, chasing this Medicaid funding, and chasing small populations. I'm concerned the big populations are going to get away from us. So if you look at smoking as an example, we have some groups of smokers who already have high rates of smoking, but they engage in other risky behaviors as well.
Mhm.
So if we spend a lot of time and money addressing those specialty populations, do we let the whole population start turning that corner and going back to higher smoking rates?
Mhm.
So, so I'm pushing back a little bit on this kind of micro focus on very small populations and trying to keep the whole population healthy.
Mhm.
And it's the same thing with opioids. If we just look at one part of the opioid problem, prescription, then we're not looking at the recreational users. We're not
Mhm.
looking at these other people. We get started in an entirely different way. So, public health, I think, is really going to step in and be that voice that says, all right, this is good work, but what about everybody? Because the accountable communities of health are supposed to address the whole population, not just the Medicaid population. So I think that's where our engagement is really going to come. And we're actually going to ask for some money to participate. Because they have gotten money, we've got $1 million in planning money, and we've got another $5 million for planning money.
So where do you go to get that money?
Cascade Pacific is who I'm going to ask for.
Okay.
And it's going to be us in Grace Harbor and Lewis County and Thurston County. We're all going to say, hey, we've been donating a lot of time and a lot of staff time and effort. We should be part of the paid planning process as well.
And I'm wondering if it's a function also now, if it's at some point, if not now, of bringing up that request and ask from the Board of Health level. Because, you know, it's easy to bypass the directors of the public health agencies in those meetings, just watching how it works. But once all the 6 county Board of Health get involved, it'll be harder for Cascade Pacific actually to not address it very directly.
Right. So, and I brought up that point. If they're going to be seriously focusing on just clinical work, why am I at this table? Why is public health here? If we're to be involved, there has to be some meaningful way for us to be involved.
Mhm.
So, not just we show up and do the assessment work for you for no charge. You know, we have a lot of expertise we bring to the table. But while we're working for Cascade Pacific, we're not working on the programs that we can build to. So it puts more burden on the county general fund to support that activity. Thank you for having me.
Okay, you want to elaborate any more on this?
That's.
Homeless, Todd's going to talk about the homeless piece.
Okay,
So
all right.
I'd like to kind of get through Debbie and then on to Lydia, and then we can kind of roll your thoughts into it
Okay.
as well.
We will hear from Debbie Riley, Environmental Health Report.
Thank you very much. I will keep mine short and sweet because we have some very important topics today. You have my little report.
Mhm.
I wanted to tell you the 2 new employees are working out very well in the programs they're in. It's been a very pleasant transition, and I think we owe part of that to having them overlap a little bit with the employees that they were replacing. It really made a good, smooth change. We still do not have a capital budget at the state, so we do not have our coordinated prevention grant money coming to the county for our solid waste program. Maria Machado, who works in that program, is still doing the solid waste program part-time because we have our tipping fee money and some of the permit fees that we get for the permitted facilities. And then she is working on Group A sanitary surveys that we contract with the State Department of Health to complete. So it's not like she's just gone to half-time or anything. She's taking some of the duties that Carol used to do before she retired that are bringing in good dollars to our budget. The other thing is the shellfish downgrades. You'll be hearing more about that, and that's why I'm kind of giving as much time as I can to the community and family health side of the house, because you're going to get so tired of hearing me talk about the downgrades. But our first meeting for the North Bay Shellfish Protection District subcommittee formation, whatever we want to call it, is tomorrow afternoon from 1 to 3. So folks from the State Department of Health will be here to talk to me and the environmental health water quality staff about what they're expecting, what we're looking at. So we're moving forward.
Is that going to be here?
It'll be over in our office, yes,
Okay.
So,
in the meeting room.
And kind of in conjunction with that, we did get our $42,000 of Foundational Public Health money that we've been working on for the last couple of years. Our first installment is here. It's dedicated to communicable disease, and we wrote it broad enough that we can use it to do investigations. Say we have high fecal coliforms out at a beach, we have to close the beach, we'll have somebody work on that. There's enough flexibility we can massage that communicable disease definition into where we need it to go, and still meet the deliverables of the grant.
Any more?
That's it, unless you have
Oh, that
questions
was-
for me.
Short and sweet, wasn't it? Any questions for her? Okay, we will move on to Community Health Report. Lydia?
So I'm going to just start by mentioning, it was in my written report to you all, but the Maternal Child Health Nurse Family Partnership Program, and I talked about how that's moving ahead. We did have a meeting last Friday on the phone with previous funder, which was Thrive by 5 Washington, and now it's Dell, Department of Early Learning. We're trying to work that contract over, and then we're connecting with Thurston County, and so it's quite this large puzzle that's being put together, but it's moving ahead, and it looks like it's going well. We're still just kind of waiting. We'll probably want to start looking to hire our nurse as soon as possible that will replace one of the 2 nurses leaving, because we still have maternal child health programs that we can have that nurse work in. So I'll be down officially 2 nurses from what we had before. So we'll want to get started on that, but it's going well. A lot of contract stuff between lawyers and things, not here, but in Thurston County, working on trying to get that all finalized and move it ahead. And then working with the national office, because they've had this happen in a number of counties now. We're not the first county for this to happen to, so they're getting better at it, but each county, they said it's a little bit different. And we were a site with Jefferson County, who now is also a site with Kitsap County. So we're being pulled out of the Jefferson site contractually and going into a nurse site with Thurston County. So it's
And the
quite a
reason
jumble.
for that?
What's
The
that?
reason?
Because we had a nurse retire, and getting nurses here in Mason County is real difficult. I put that in the report. Financially, pay scale and everything, when we have Kitsap County and Thurston County so close to us.
Okay.
And the amount of money it costs to train one of these nurses is about $8,000 to get a new one in. It's a lot of money. Since this is trending in all of the smaller communities, they're joining with a larger community that has a better pull of staffing and nursing. We decided with that one nurse suddenly leaving, it was the time for us. We had been thinking and talking about it for about 5 months.
Okay.
But that was the impetus to go, okay, we need to move ahead because it wouldn't be financially responsible to start and try to train another nurse.
Okay.
So that was the reason why we made that change and
Thank
are
you.
working in that. So, but then I also wanted to just talk about a little bit of some exciting news, but I'm first going to let, it's good news too, but Abe Gardner, if some of you might not have met Abe yet, others know who he is. He's working in our opioid, let's see, I just blanked on PDO, Prevention Drug Overdose Program, all these little acronyms.
Yes.
And he's been working in that since March. We've had the contract since January, and then we hired for it, and he's doing the drug overdose prevention program. And it's a pilot program, and we're doing it, there's 3 pilots in the state. We're one of the 3. The other 2 are very different. So each of the pilot programs is being done to the needs of the community. And ours is the only one being done like ours is, that Abe's doing, and he's doing a great job. We just sent off our report to the state, finalizing the first year of the program, which only ran 6 months. That's because that's when they got us the money. So, but there are 3 years to this program. And so they're letting us roll the money we didn't use for this first part of the year, the first year, into the second year. So that's coming on Amendment 16 in the Concom. So you should see that coming through. So Abe's going to talk a little bit about the accomplishments that happened in the last 6 months with this program, and then I'm going to take it back and talk about some new exciting news we have. Okay, I'll hand these out. You need one here.
I can hand these,
Yes, I'll hand
these around as well. That's part of what we've, and some of these points you'll see, I can speak into great detail. There's a couple that Dr. Yu knows a little bit more about, however I know kind of more of a broader view, but, so in the last 6 months, we've had 10 reported saves since February 2017. Saves being from opiate overdose, using the drug naloxone to, so they survive their overdose situation. Although we know there are a lot more saves happening in the community, and we're working right now on developing a process to collect that information with EMS and other, because right now we get information through the hospital, the emergency rooms. And so that's a reported save at this point. So working on collecting more data. We have created that trifold substance abuse resource guide. It's specific to Mason County. It's currently and continually being updated as resources in the community, as we gather more resources and more places are offering services. I attached the personalized business card on the front there about Stop Overdose, which I have a work cell phone that people can get in touch with me, because especially the active using community, they're going to be really hesitant to call a county number. And when I call from a county number, right now it shows up Sheriff's Office. So we've found it to be more effective to have a personal cell phone, or a work cell phone. We've handed out over 500 of those trifolds in the community so far. And have started to get some really good response from them. We've held two community forums, first being in September, second one was in April, and as Commissioner Schutte explained earlier, we are working on planning and supporting a third one this November, the 15th, happening in North Mason. Right now we're holding monthly workshops at Community Lifeline. We talk about what opiates are, what happens, how to identify, and most importantly, how to react to an opiate overdose situation. We've held 3 so far, and we're planning on holding them monthly moving forward, and we're also working I'm working with Bo back in the fire chief in North Mason to work on getting some up in Belfair as well. So they're open to family members, active users, friends, and professionals, and so any and all community members. And we allow for a time at the end to offer some free naloxone kits. So far as the naloxone goes, we've resupplied Shelton Police Department with 20 kits, so all their officers have them. Just recently, we were able to supply the Mason County Sheriff's Office with 50 kits, so all their deputies should have them as well. They've all been trained, and we distributed 90 plus kits in the community so far, and I've got a shipment of about 96 more that should be here this week that we're trying to get out in the community as soon as possible. So far, we have standing order prescriptions for naloxone that have been written by Dr. Yu specifically, and they're implemented at Neal's Pharmacy and the QFC in Belfair. And then Safeway and Fred Meyer in our community already have them. I believe it's a corporate-wide standing order procedure they've implemented, which is fantastic. So that means that doctors don't have to specifically write one for you individually. You can go to that pharmacy, let them know you have the money for a kit, and they'll get you one.
Is there a date that's not good anymore?
For the drug itself?
Mm-hmm.
Yeah, they're usually about an 18-month to 2-year shelf
Okay.
life.
All right.
So, yes.
Okay.
As of right now, and we've started talking about, because like with flu vaccines and different epidemics, they've been able to extend those shelf lives, and because of the epidemic that we're in with opioids, we're trying to see if we can get something, the powers that be, to maybe extend some of those
Okay.
expiration dates.
Something that you as a pharmacist might look into helping us push through, because we've talked about it at the state level already, and they are considering something like that to be done.
And so Northwest Resources, Mental Health Professionals, LLC in Shelton, and Peninsula Community Health in Belfair now provide medically assisted treatment options such as Suboxone and naltrexone. Local courts and prosecuting attorneys are now accepting medically assisted treatment clients in the therapeutic court system. And I believe we touched on earlier, Dr. Yu is supporting a potential pain clinic by Mason General. And we've also been partnering recently with Thurston Mason BHO on receiving more kits as well. So those are some accomplishments and things we've done so far in the first 6 months.
So I would describe this program as being a snowball, and it's really starting to gain momentum. It's really exciting to see the last class that Abe had this week. Was it this week or last week?
Just last week.
Last week here at Lifeline. It's growing as the people learn about it and come and want to learn more about using naloxone. But as Dave was talking earlier, we want to focus more on just the drug overdose, and of course our opioid plan that Dr. Yu wrote goes beyond that. It goes into treatment, it goes into data collection, and so we are working on all 4 areas in the program, and we're able to even use this money to do other things, to expand out. So it's been exciting to see what Abe's done in the short time he's been here, and we're being watched because we are a pilot program in the state, so that's exciting. But the next exciting thing is if you turn your paper over, we applied in April for a federal Office of the Justice Programs grant for $300,000 for 3 years, and we just found out on Friday we received it.
Yay! Congratulations.
Yeah. So, and we thank Deb Denathan,
Excited.
who's no longer here at the county, but was the grant writer on that, and she's the one that called me because we had no access into any of the stuff, and she said, "Congratulations, you got it."
Wow.
So that was 1 out of 10 given across the nation.
Wow.
So will that money be used for?
I'm going to explain.
I'm
that.
sorry.
That's okay.
Getting ahead
So
of
yes,
myself.
it's, so I don't know the details of it yet because we're still in the process of getting the fiscal officer changed, and Kevin, your name's on one of them, Commissioner Schutte, your name's on it, which is fine because you were one of the ones that helped us get this all through. But we're getting that all changed so that we can actually access the grant and download it. So we'll know more details hopefully by next week. We've put a few calls into the federal level, but of course, you know, they end later than we do, so, I mean, earlier than we do.
Could you reach out to some of us when you find out and pop us an email?
Oh, of course I will.
On it.
Yeah, there's going to be actually the newspaper, Community
Okay.
Life already just emailed us about an hour ago
Okay,
because they
great.
got wind of it, and so they want to do an article, so we will be putting lots of information out
Okay.
on it. So I wrote a few things down of kind of what's going to happen with this grant. We patterned it after the grant that we got from Department of Health that Abe is working in, because at the time when we applied for this, it was only a few months after we got the Department of Health grant, and we were told it was only through August. So we thought, well, that's not good, we need to keep doing the work. So we patterned it after it, which they really liked. But then we found out that this grant's continuing for 3 years as well. So we thought, okay, but there's a lot more work to be done, and one of the areas was treatment and connection with treatment and connecting with the jails and the incarceration. And so these are things that the grant from the Department of Health doesn't actually allow us to do. So this grant, we wrote it a little bit broader, knowing that we'd want to do more things. And so we're excited about that. So what it'll do is it'll increase the community health program worker from 0.6 to 1.0, so a full-time FTE. So Abe will be able to apply for that, and I think he's going to. And then we will also be able to probably look at adding another a 0.4 possibly, we're not sure about the FTEs yet, additional worker to help, maybe taking over some of the work that Abe's been doing, and then he can move on and do some of the expanded things that we've been looking to do. So more treatment and recovery outreach education will go on, community outreach education in schools, fairs, individuals, families, naloxone outreach campaigns, which we're doing now, but we can expand it, and also for users and families.
This treatment and recovery outreach, what does that mean?
Well, what it means is we want to get a system in place, and that's what kind of we're going to focus on. In other words, working with all our treatment, making sure that when someone's identified somewhere in the community, there's a path to get them into treatment and to follow up with them. So that's kind of what we're looking at right now. The money's there. They want to see a shift in people getting into treatment from incarceration or from the streets or from therapeutic courts and staying with it. So that's part of what we're going to try to help work with, get our partners together. We even have to have, as you see, a little further MOUs with all our partners, which we have partners, all these partners in the community right now, and they signed all letters to say they're part of this effort. But we're going to actually have formal MOUs with them, working with them on trying to get people down the road. So in other words, we'll hear sometimes that somebody had trouble getting treatment in the jail, MAT treatment in the jail, medically assisted treatment. And then, of course, when they get out, we don't want them to just disappear. We want them to have a plan and a caseworker to move them. And some of that's going on in like therapeutic courts, but we're supposed to create a system so it works a little bit smoother. So that's kind of the goal.
Is that where the building, the OPD building will be taken
Well,
back to
I'm
the...
saying, I apologize, but you know, as you know, I've been looking at the BHO level, and I don't see any coordination. And if I don't see it, it's not obvious. It's not that it's not happening, but I don't see where this might work with what the other things that are happening. So I guess I'm hopeful that
Well,
and our mental health funds, our local ones, because frankly, the work in the jail is paid for by the BHO. We have a grant that was supposed to have been helped be that transition out, and so if our current efforts need to be retooled, or I just want to see, I want to see how that's seamless. If you guys are coordinating, then what is the BHO doing? And if BHO's
we're not coordinating. This grant is supposed to help make sure or take a look and see that it's happening and that it's clear in the community. So if it's already happening in some places, so we find often that some people don't know what the right hand and the left hand are doing, and that's kind of what they would like us to show, is diagram out what the right hand and the left hand are doing if we can. So we would only complement what's already going on. We wouldn't be doing it for them. That makes sense? Well, we have the opportunity to figure it out. How about we put it like that?
That's great.
on some of these, and especially with that grant, and taking into account what was just said, this may sound very simplistic, but what about the idea of having a weekly or bi-weekly meeting, each of those things like some other group might have, like Al-Anon or whatever, and you have it bi-weekly at, for example, St. David's, and wherever they're at, and just give them the options each week, give coffee and cookies, have them come in. This is where the BHO would be one of the options, I'm sure. If you have the options, you keep presenting it to them. Just like anything else, an addict is an addict until they finally stand up and change it. But they have to do it 100 times, have it put in front of them 100 times, and it may be that 100th time, because of this money, that might give them the opportunity to put that, or the Suboxone treatment, or even a methadone, or whatever, but at least they start the process, and we start to whittle down on some of these numbers.
Yes. And that is what this meeting's about, that he's been doing.
But I mean regular meetings.
Yeah, and I actually, to that point, me and a couple other gentlemen in town just started a meeting. We just had our first meeting last night, where our goal is to partner with the resources in town, because AA and NA can only do specific literature that's been approved through those entities. We wanted to start a meeting in our community that allows for any of our community resources to present that opportunity and make connections personally. So we just kicked one off last night that moving forward, we're hopefully going to be able to provide some of those opportunities.
And that'd be wonderful. What about if you kick it off at the end of the meeting, where you stand up before me saying, we have options to get you to this, this may change your life in that way, and after we're done with this meeting, if you have any questions, I'd be more than happy to help get you connected with that particular entity, and just keep doing it until eventually they choose you, or choose one of the options.
That is the opportunity with this grant, is we get to go longer,
No, I
and
got-
we get to add
I got
more
the grant,
things
that's why
to
I was,
it.
I
Yeah.
understood it, that's why I was making
Yep.
that recommendation.
Yeah.
Or
Yeah, no.
asking if you would consider it.
Yeah, that's, you bet.
It's in the plan, and yes, it's a perfect idea. Yeah, definitely. We need more face-to-face, more encounters, more opportunity, and constant education and offering services. Like even in the meeting they're doing once a month, because they're doing that monthly now, is bringing in providers so that we can actually connect users up with providers that come to the meeting so they can do a face-to-face. Because sometimes cold walking into some place doesn't work really well. They need to feel like they know the face they're going to
But
see.
the more you put it in front of them, that might be the day they say to
Mhm.
themselves,
Yep,
I gotta do something.
agreed,
You know,
Yeah.
they say it themselves all the time, they just
Mhm.
don't do anything that's not in front of them.
yeah. So anyway, you can read the rest, that we're just expanding out in this, and really it's open to Dr. Yu. We haven't talked, I informed her of it yesterday. She wants to sit down and think about other ways that we might want to utilize this money. I'm told that these funds they're pretty supportive, and you get to design the program. Now, things were already put into the grant when we wrote it. We just need to make sure we stay within the boundaries they allow us, but I don't think it's going to be a problem. So, anyway, very excited about it, and excited to hear more, to actually get the grant and look at it, because I haven't even actually seen it. I've seen what we proposed, but I haven't seen what they accepted and what they agreed. But they did give us the full amount requested, so.
That's exciting. Very good.
So, excited about it. And then I think we're going to go from here, we're going to roll into Todd's presentation, which if you're sitting, you may want to turn a little. He has a PowerPoint behind you.
Hi, Todd. Huh?
A little different.
Yeah, a little bit
A
different.
little different twist on it.
Yeah.
Keep it interesting. So I've given a little bit of an update to the Planning Commission, City of Shelton yesterday, and then and here today. So not knowing who, I thought I'd give a little bit of background, so I know some of you know this intimately in everything. But what I thought would be maybe important is just to really start off with is, what are some of the funding sources for the homelessness, and probably back up on Todd Parker on Mason County Public Health and housing and behavioral health program coordinator. And so kind of really what I do is organize, coordinate, manage, however you want to describe some of the money that comes in. And so this Consolidated Homeless Grant, it's kind of nicknamed the CHG, and part of that is the HEN, which is the Housing and Essential Needs. And then we have local document recording fees, and they're broken up into two categories, the 2060 and the 2163. The 2060 usually goes to capital purchases, shelter operations, things of that nature. And the 2163 is mostly around programs and services that are in the community. And then treatment sales tax, also the 1/10 to 1%. There is a component in there that they say it can be used for housing as long as the component of treatment services for mental health and clinical dependency. So what I'm going to do is talk about, look at us, now where to go in our community. So funding sources and where to go. So the Consolidated Homeless Grant, we pretty much do a direct award of Crossroads Housing. Where this contract cycle is a 2-year contract. This started in July 1 and go through June 30th of 2019.
What's the total amount on that?
Sorry. It's, let's say, on the CHG portion, it's about 200. And then there's a little admin piece in there that we would be paying, but the pass-through is around 200 or so. The HEN, it goes to Community Action Council, Housing Essential Needs, that's very unique and very specific. So while it's a significant amount of money, about $500,000 annually, they have to be DSHS qualified, and they are referred to this program for Community Action Council. So this serves a very specific need that way. And then our local document recording fees on 2163 of the program and services side of it. Crossroads Housing, that's about $162,000. We have Community Lifeline, does case management services, works predominantly with single homeless adults, very some of the hardest to serve. And the HOST, that's Housing Options for Students in Transition, so it's really the youth component. Turning Point and Domestic Violence Center, and now Sexual Advocacy. North Mason Resources. And then right now, the 26th year of the capital, we're kind of waiting to see what kind of programs and some of the needs as to, we haven't RFP that out yet, just the request for a proposal out just yet. So again, that's not, we see that a little bit more project-based.
The Turning Point, what advocacy?
Sexual assault.
Sexual assault.
Yeah. And we changed their name and we don't have the full thing correct. It's, yeah, longer now, but more services. And then with the treatment sales tax, the housing component goes to Northwest Resources, so they do a big component on helping people get into substance abuse treatment, and that, but they do have some money set aside for housing, so they can other treatments, Oxford House, Fresh Start, and those kinds of things, so they help in transition and help to make the recovery strong and stiff, so less chance to relapse. So that's kind of where it goes here in our community. And this is, so usually I'm talking about, housing is mostly probably centered around, on the homelessness side of it is where this is. And so there's many other components. And so part of my presentation is, slightly interactive. So we look at it, so what's missing too? I mean, there's a lot of other parts about housing. There's no wrong answer.
Is there enough available? Probably not.
Yeah, right, yeah. I think people, they're in services, can we actually move them into that?
Yeah. Housing stock.
The affordability.
Yeah, affordable. So there's that whole, so if you look at it, so those are the perfect thing, that's what I was hoping to hear. It's really, if you look at the housing comp plans, whether it's the city or the county, that's kind of where they focus. A lot of the information and the data is all around affordable housing and how does that link and kind of where are we going that direction. So that's where I think we can kind of work together. But I also was like, I knew the Board of Health, I know it happens every month and all that, but I thought, this is for me because I know what you do. I know you know what you do. But I thought, this is where I want to kind of tailor it a little bit to the audience. They always say that's something to do when you present. So I thought you have a big mission here, supervise all matters pertaining to preservation of life and health. So I thought, okay, all right, awesome. And then, but I thought that the two of all the, A through Z type things, the ones that stood out was, maintenance of all health and sanitary measures for the protection of public health, and then enacting local rules and regulations. So I thought, okay, that's where I thought I'd kind of tailor this a little bit from some of the information I provided you. I provided you a very general and kind of overview, and then a detailed report that we're getting ready to release to the community. So I think where we kind of look at, a little bit with the Board of Health and some of the preservation of life and health and sanitary measures, is I think if we kind of look at, our point in time count, using that as one measure of homelessness, we know it's not the only measure, and under count has some limitations when you're trying to physically count people, but in this case, you're actually interviewing them, and I think it's a big component. You actually fill out a survey, sit down with folks, face-to-face, it could be 5, 10, 15, 20 minutes that you're actually talking to somebody. It's not just also around tally. So that in itself, trying to do it, especially in remote areas like our county, provides the calendar. So anyway, the total count 262, and then they vary slightly from what I have because I've kind of been going back and forth with the Department of Commerce and what they're counting and what they're not. And so what you see up here is what we physically counted. So what they've kind of done since that time, and didn't find out until about a month ago. So this happened in January and about end of August and early September. They said, well, we're going to pull out all the folks that are in the structure lacking amenities category. And so I'll show you.
Pull out of the count?
Yeah, pulling out of the count. So structure not meant for habitation. And so that's, so that's, so I thought, well,
So they're in
this is
a
what we
structure,
counted.
but it's not meant to be habitated.
It would be,
It's not meant for it, but the strange thing is, so here's what I think is an important point, to really look at is, you have one side, like an RV, for example, that, so usually they define a structure not meant for habitation as basically not having running water, or it works, the ability to cook, bathe. So you might have that, but it doesn't work. That's that way. So I think the really thing that kind of falls in the middle, or it has fallen in the middle, is the RV situation. So you have the one organization that's looking back at like a 2008 document, and there's two places that, maybe it might read that way, but I might read it a different way. It's, kind of one of those things. Doesn't come out and say that that's not, you wouldn't count them as being homeless. But it's, but then on the building coding planning side, when, I've talked on that, that is as I say, like statewide department, they look at things like RVs that they're not meant for application long term, it's seasonal, it's temporary, it's short term. Even an RV park, you can only stay for a certain period of time and you need to leave. And there's a period of time before you can come back, and so many times in a year. So there's a lot of rules around that. So I kind of feel that we have this group that's kind of getting lost, if you will, in counts and things. So hopefully, I guess our Kate and everybody kind of will work through those things, but we will, still do that. The other thing that's kind of a challenge when we're actually doing the counts is that folks that might be in that situation, they themselves may not think they're homeless, so, this is my home. But by definition, sometimes it comes down to definition, but, they may not admit it, so they may not show up in the count too. So, some things to work through. But
So-
I think, go ahead.
so when we're talking about structure not meant for habitation, 26%, is that the 26% of this number up here?
Of the unsheltered number,
Okay, all right.
yes.
And then the vehicles, 24% of unsheltered.
Yeah,
And abandoned building,
3% of the unsheltered.
unsheltered. Okay, we're looking at unsheltered, okay.
So where's the shelter?
Well, shelter is so that in our community, that is three main sources. They have the Turning Point, the domestic violence shelter. have Community Lifeline for the single adults, and then you have 7 units in family shelter at Crossroads. And then they do include the transitional housing projects, which really are only about 12 units in our community, but that's, people can stay up to 2 years, but their exit would be homelessness. So they still consider that group, since it's short-term temporary housing as homeless. So again, I guess when you,
It's homeless with a home.
yeah, but, you know, when you come back to the RV, it kind of has a
Oh,
home and not that, you know. So,
Right, right.
interesting.
Okay.
So that's our shelter. So our shelter count historically, if you look at the last 10 or so years, has been pretty much the same. It's all been around that, you know, anywhere from 111 to 118, because that's how many beds we have. So that's going to kind of stay unless we got more shelter space. Then we see that actually go up. And as the unsheltered, you're going to see a lot of variation when it comes to the methodology and a lot of other things like that throughout the years. So I think, you know, again, to kind of bring it back to like the public health and things, that, you know, what are some of the conditions like then for some of the folks if you're living outside, if you're living in an abandoned building, if you're in an encampment and there's more than 2 or 3 of you, there's 10, 20, 30 people maybe. Well, then what is that like? And what's the health of it? What's their environmental health impacts? So I think those are some kind of, you know, maybe some questions that just stimulate some thought. So what I kind of wanted to kind of take some information as I've been trying to, you know, we've been forging partnerships internally, you know, for the building planning and the code enforcement side, and then kind of looking a little bit about, you know, what that looks like in our county. And so when we kind of just maybe back up and call it like maybe substandard housing, is right now they have 48 open cases of code violations that, around RVs. And so there's 13 in the Belfair area, and then 22 outside of the city limits, and then the balance is kind of scattered around the county.
That's not, you're not getting a real accurate count, you're just what you can see. But then
These are
there's the
open
ones
cases.
out, okay.
These are actual ones that they've written a code violation.
But there's more out there that they have not written anything on.
Yes,
Absolutely.
absolutely.
We're driven on a complaint basis,
Yeah.
not necessarily
Right.
a observed basis.
Right, right, okay.
So there's kind of, yeah, there's a different size of what's that, and then there's a whole lot of other.
Yeah, okay.
And so trying to put our finger or wrap our hands around. So what I thought would be interesting is just to pull some of the comments section from there to get a flavor for some of the complaints and some of the things that they were seeing. So RVs without a septic. RV behind posted trailer discharging sewage connected excess solid waste, including in RVs, no septic. Again, that's kind of a common theme. And then 2 unpermitted mobile homes being lived in, sewage running down into swamp or creek outlet. Yeah. So those are the comments for real.
Now, are those the accusations or is that the determination? Because I
Yeah.
can't tell you how many times I've gotten that phone call and then staff has gone out there and that's not been accurate.
Well, these are actual,
Findings from the employee?
documented.
Gotcha.
And then, so, I guess to kind of bring a couple things together then is, you know, our housing coalition and some of the efforts in the community are, you know, aligned with the vision of Washington State's strategic plan that no person left living outside. You know, so that's, you know, collectively what we want to do, and so kind of what's next and how to do that. So I mean, I know these are really broad strokes, but you know, connect our excuse me, current services to what we talked about earlier about what's missing. So we fund one big area, but then there's a whole other area that we can, or like you brought up, all the substandard housing that's out there that might not get a complaint, but, and that's the biggest thing we hear is people are afraid to, as a tenant, they're afraid to voice anything because they're afraid the landlord may kick them out.
That's right.
Or undocumented, and they have nowhere to go.
I know an example just in my neighborhood that the electrical is not up to standard, but they're afraid to say anything.
Yeah, so it's a tough situation. So that's hopefully from the policy side, and we can think and, just keep the dialogue going about, how can we address that, what powers do we have, authorities, all those kinds of things to try to make a difference in those areas. Definitely, strengthening community relationships, working together to make that happen, and then explore local rules and regulations that are necessary for So that's all I really had. If there's any other questions or anything that with this material.
Very, very interesting,
On
the
some,
statistics.
on some of your things you're doing here,
Yeah.
I noticed, you whittled down pretty far what some of the issues might be. And I know that you always looking at different options. Have we thought about changing up a little bit? We keep using whoever comes in to make us an offer to do something. We thought about, and I talked about it a long time ago, so I guess it's only a softball, going out for RFPs on things that you think might have a bigger effect, a better effect compared to what we're currently doing. One example might be, you see that you have an issue with people that aren't taught how to get a job, basically. So you end up homeless because they're not doing it. We were to go out for an RFP for somebody that's going to give them a weekly class on how to go in for an interview, how to dress, that might be something different.
Yeah.
Have you thought about changing it up a little bit and have any ideas that might help us to have a greater impact in the future on actually getting them off the street?
Yeah, I think the kind of answer is, keeping it open in the sense of looking at, the kind of the greatest needs. We're still trying to work with a lot of our current providers and use quality data and measuring things so that we can find out, what those true needs and services are. I kind of, put in here the strengthening the community relationships. So it's, look first at working with the Peninsula Credit Union as an outreach specialist, financial outreach person that meets people one-on-one and helps with budgeting and all that for low income and another ALICE program. And so it's, but we're not really tapping that. I asked them, how many people are you seeing? 8. Okay, so I think our first thing is how can we get you to see 20 or 30 people, or how can we better partner with WorkSource and those kinds of things, and then look at, hey, if that's not quite working, then like you're saying, who else can we bring in for the employment piece?
I wonder if people are somewhat intimidated by going to a bank.
Well, that's a great point, and that's exactly who does outreach.
Okay,
So
he
they
goes out. Oh, my God.
All right, Dietrich, so much for you being quiet right there. Everybody okay?
At least it didn't land on your head.
The other,
So that's why he is doing outreach, he's trying to take it so they don't have fear.
Okay, so he meets them elsewhere, restaurant, a library, wherever, okay.
Or the agencies that are working on the folks.
All right,
They'll meet them
but
in-
he's not getting a huge response.
Last I talked to him, so it's,
Okay, so how did
Chris Porter is, so it's just like, how can we help them out?
I have one more question on that. Statistics are always important. What you've given is wonderful, but then I look at the actual statistics year for year on your sheltered, unsheltered, and your totals.
Yes.
That I'm a little bit uncertain when I'm looking at these numbers. 2010 to 2011, there was you're looking at a base of 200, an increase of 145. That's 74% increase. That'd be one thing, except for the next year, it drops down by 70%. You lose 125 of those people back are gone. Then it stays that way for a year, but then the next year it goes from 224 to 351. So you got another 125 that just showed up. Well, the year after that, 125 of them disappear again, back down to 250. Then the next year it goes up to 416. So 175, and then the year after that it drops down by 200.
Yeah.
When you're considering a base of 200 or something around that, that's a lot of difference. What do you think is creating that? I can understand if there's an event, and I'm looking at the years, I'm trying to put a correlation to an event, and I really can't.
Yeah, no, it's, I'm right with you. Again, it's the unsheltered number in particular that you're gonna see balancing around, and that really just comes down to the methodology and who was doing the count at that time. And again, I don't think it's anybody's fault, they're doing the best that they could under the circumstances that they had. I can kind of comment on, and some of that I don't know the history and the depth, I've tried to ask a little bit, but it's hard to, everybody's, oh, we do this great job, and we did all this counting, and then you look, and you're like.
I've been watching for 4 years,
But
4 to 5 years.
2016
to
in
count.
particular, they did enter a lot from the Shelton School District that really did fit the category. So there is a good 160-ish or so, I want to say. So that anomaly is, that I can actually account for. The
And
rest of
just
them,
in general,
I think it's just a
just
methodology.
in general, the methodology was very different from year to year to year.
So if nothing else, we're trying to keep it
Definitions
consistent,
tend to change, we talked about that earlier.
consistent methodology.
How they change definitions will change with the county stuff.
'Cause if that was accurate, we sucked in 2016, but we rocked it in 2017.
Well, it could be too that, some of these people you're counting move from one place, sometimes move one city to the next. And then they come back, and then more comes, and then they go, and so it's,
And I thought about that, but not at 100% increase.
Yeah.
Maybe
Well,
there's-
part of
You have
that.
small denominators, though, really.
Yeah, that's true.
The one, I was on a DSHS presentation last week, and they were,
60,000, that's a small denominator.
they were talking about just childcare resources that were available for people experiencing homelessness. And at the end, they kind of showed, hey, we're going to show you the point in time count. And they're like, wow, look how much we've dropped from 2016 to 2017. And I had to jump on a little webinar chat box and say, HUD and McCummers decided to remove that category of unstructured, but they weren't aware of that. And it was like, oh, well, let's take a look at that, or maybe we better ask. And so
Well, I kind of
they didn't put a caveat, they didn't put a little asterisk next to it.
That's
And
right.
so I think if there are major changes, we need to identify, like, this influenced the calendar, this is a rule or a definition of change or something.
I kind of, I kind of correlate this as being how many people watch this show and how many people, well, they don't interview everybody in the whole city, so you really don't have an accurate
Well, that's my point I'm trying to figure out. How accurate is the information? Is it real? If it's got that much of a variable?
So what I'm trying to do in that is take this for what it is. Do the best that we can, and it is what it is.
Yeah.
Outside of that, I think a good measure and a good indicator is coordinated entry, and so that's people who are experiencing housing crisis, and that's supposed to be their first response. So as we strengthen community, as we strengthen a lot of the community relationships, we might even see a little bit of an increase because now we're driving more people in. And that's okay, but I think that gives us a good picture over the year, like how many people. And it's in the detail, or it's on the back side of the summary page. It's up on the right. There's 10,047 individuals, 345 households. So that's what was seen over the course of the year. And then the other thing I have in the whole report, I think with our veterans, we have a lot of different indicators, and so we have like their standout. So they counted 21 last year. We counted 14 on our point in time count. If you look at coordinated entry out of those 345 households, there was 10 that came through. If we look at Northwest Resources and how many veterans they served, there was 6. So I think that's one subpopulation that we have like a lot of these little markers for, that I think that we can get a pretty good idea that point in time count, but at least tell us with all these other things, are we moving in the right direction or not? So I asked you for how many different indicators can we get?
This was very interesting.
Yeah, and the school districts, I have a big kind of summary on there for the county and each one, and it's one of the just for your information, they do include like couch surfing is doubled up as homeless. But the other thing that's different is their number is cumulative throughout the course of the year. So when you heard 430, that's how many people have experienced homelessness at some point over the school year. So if they've resolved, they still stay in that count. So the person over at the school district, this is Shelton School District, said maybe at any given point in time, there's about 130, 140
indicators, there was 43 unaccompanied youth. That's, parents, they don't have any attachment. And so to me, that's like, we really holding on that piece. Because others, they might be with a grandparent, friends, or they're doubled up. and
That's right.
They still have a house.
Right.
Not the best of the situations, but it's better than unaccompanied youth. So we just got to figure out stuff now, what can we do to address that? And we don't have these shelters, we don't have some things that we can do, so, but things are working on. So back to
Okay.
this.
Dropped off.
Yeah. All right. Well, thank you. Okay.
Thank you, Todd.
All right.
Do we have any other business?
I have a couple really quick
Okay.
things. So this came out just 20 minutes before we met today. And there's a service called Josephine, which does meals cooked at home for sale.
Oh,
That's yours.
there's some extras here.
And then we'll get that. This is a letter that came out, it was just sent to me today from Seattle, King County, Tacoma, Kitsap, Snohomish, to address, the company's called Josephine. They cook meals at home, they cook things out on Facebook, you stop by and pick up your home cooked meal on your way home. And
Health issues?
you can answer that question.
Is you getting there?
So,
Yeah.
so these 4 agencies are taking the lead, kind of move this issue up to the Attorney General's office, see if they're going to get a ruling on it. Because technically they're in violation of the law right now. We don't need to add more laws. The laws are there.
Right.
So they've asked Josephine to come in and meet and try to work something out, and apparently nothing has happened. So the corporation behind this is declined to meet with public health to say, how can we make it, if we're going to do this, how do we make it safe? So I think that's their issues. They're trying to push this
Okay.
forward to force that issue.
My
So-
sister has a jam and jelly business in Renton, and she has to rent a commercial kitchen, you
Right.
know. Can't do it in her home.
Right.
Yeah.
So in Stevens County, we used to have a mobile kitchen for people to do canning and all sorts of
Oh.
things. It was in a trailer, you pull it up, set it up,
Do their thing,
yeah.
and it was
Pick it up,
all
yeah.
approved.
And they had a mobile chicken and beef butchering as well. That the chicken bunkers and
Mhm.
things. So, it was,
Yeah.
so I mean, there are ways to address things.
Sure.
The last thing is, it's a heads up for November. In the next couple of weeks, we should be coming out with the legislative agendas. I have Washington State Public Health Association in 2 weeks. Right, Debbie and I are presenting, I'm not presenting again, I guess I broke in talking about kind of community health. So we'll be there that week. And then at WASAC, we're sitting in on the WASAC legislative agenda, as well as trying to get our legislative folks in coordination with WASAC. One of the pieces of legislation that DOH is going to be bringing forward is the Tobacco 21. So it raises tobacco and vaping and all those up to 21. So I'll want some feedback from the board on, do you want to support it, or do you not want to support it? So if there's some materials that you want me to put together before next Board of Health, let me know and I can put those together. But that's going to be a big one probably to talk about.
Would be good to see the correlation between 18-year-olds smoking and vaping versus 21-year-olds. The health issues that happens within those 3 years. I don't know if we can do that or not.
There are some preliminary studies, not so much on the vaping,
But smoking?
but on smoking there's some. And then there's the liberty issues on the other end of the question. You know,
You
for
could-
example,
Yeah.
I took
What-
a bunch of soldiers to Iraq for, a year and a half, and brought home, and maybe still couldn't have a cigarette when you got home, if this law went through.
Oh,
Because they wouldn't be 21.
Because they wouldn't be 21. I had guys that went
Oh.
overseas looking at 18 years old. So if they're old enough to go to
Fight
war,
for the
are
country.
they not old enough to have a cigarette?
Well, and they probably, the alcohol over in those countries too, were they able to drink over there?
Oh, no. Oh, no. General order number 1, no booze.
Okay,
So,
but then the cigarettes, yeah,
Yeah.
okay.
So it's, there's some issues to talk about at the next,
Mhm.
Does Wasalvo have their own legislative?
Yes, we have our, and I'm on the budget committee.
Is there one or two that are rising to the top?
Well, what we're all concerned about is Hearst. And Hearst is going to drive a lot of activity. The cigarette bars, or the cigar bars, hookah bars,
Right.
will probably come up again. And I think they have one or two on-site septic bills that they're looking at. So this last year, they made some real progress with Griffey's bill that will allow us to have some flexibility in how we deal with on-site septic. So, yeah, yay. So if the board needs anything, any information, I'll try to put out a list of what I see coming, and then I can give you some feedback.
All right.
Thank you. Do we have any public comment today? Well, any? Okay. We are going to adjourn the meeting for today, and the next meeting is November 28th at 3:00 p.m.
Okay.
Adjourn.